Namaste. Hearty welcome to all the participants and the Easy Ayurveda family to 11th session of GURUKULA. Today we have with us Dr. Padmanabha Rugvedi sir. Being a Kai Chikitsak, Padmanabha Rugvedi sir is serving as Associate Professor in Department of Sharira Kriya at Ashwini Ayurvedic Medical College, Tumkur. The focus areas in clinical medicine for Sir are diabetes mellitus, hypertension, rheumatic conditions. Sir has 15 years and more experience of more than 15 years in the research field and also in the academics. Sir has been active in various fields. As a researcher, Sir has worked with FRLHT, the Himalaya Drug Company, and Dabur India Limited, involved in new product development and clinical research on herbal products. Sir is experienced in phase 1 to phase 4 clinical research of herbal products and related regulatory frameworks. A vast teaching experience Sir has as academician and also has various related activities with academics. Felicitated with many honors and felicitations for all the achievements that Sir has. He has presented many papers on different platforms, seminars, workshops, and conferences, and was a speaker on many instances. Sir also has many publications in his name. So these are some of the criteria to add on to the profile of Dr. Padmanabha Rugvedi sir, who is a guest speaker today on the platform of GURUKULA. So today, sir's topic will be challenges and scope of Ayurvedic management of diabetes mellitus. So hopefully, we will have an enlightened session from sir. Dr. Padmanabha Rugvedi sir, welcome to GURUKULA and over to you, sir. Namaste.
Namaste, one and all. Thank you for Raghuram sir and team for giving me this opportunity to present some of my views on the topic of diabetes mellitus. In particular, some of the challenges like we Ayurveda physicians face in the diagnosis and management of diabetes mellitus. Due salutations to the Lord Dhanvantari before we start, whom we consider as Adi Guru, Adi Vaidya. To start with, in this presentation, I will be trying to focus on this topic from the viewpoint of diabetes mellitus. Why I am stressing this point is because the viewpoints from Prameha and Madhavbaug of looking at diabetes mellitus, these are all overlapping and sometimes very confusing from the different viewpoints, like whether we have to call it as Prameha or Madhavbaug, and these debates have been happening since long, and there are different types of viewpoints regarding whether it should be called as Prameha or Madhavbaug. Nevertheless, it falls in the category of larger domain of Prameha, and also the Madhavbaug being the subunit of Prameha. But when the patient comes to us, he comes with a ready diagnosis of diabetes mellitus. So now it is for up to the physician to look into this, like what history he has and what kind of presentation he has with the diagnosis of diabetes mellitus, so that from that viewpoint I would like to carry out this discussion. In this presentation I will try to discuss in brief about the overview of diabetes mellitus, and then the challenges in diagnosis and management, and also just pitch in few possible scopes in the diagnosis and management of diabetes from Ayurveda perspective. Diabetes is a chronic disease that occurs either when the pancreas does not produce enough insulin or when the body cannot effectively use the insulin it produces. So these are the two possible scenarios. Either the pancreas is not able to produce enough insulin, or the body is not able to effectively use the insulin produced in the body. And insulin is a hormone that regulates blood glucose. This is just taken from the WHO site, wherein they have given in a very simple language for easy understanding. So hyperglycemia, also called raised blood glucose or raised blood sugar, is a common effect of uncontrolled diabetes, and over time leads to serious damage to many of the body systems, especially nerves and blood vessels. So this is the pretext of the whole clinical scenario. And just a note on insulin, glucagon, somatostatin hormones. So in Ayurveda, like some experts consider these to be related to Vata, Pitta, and or Kapha, Pitta, Vata, and present the view based on this hypothesis, like these are related to individual doshas. We are not going in detail into that, but just from insulin point of view, I am just putting that pretext. Main symptoms: sudden or gradual onset. Usually sudden onset we find in type type 1 and gradual onset type 2. In type 2, the symptoms can be mild and may take many years to be noticed. Like typically it presents with feeling very thirsty and needing to urinate more often, blurred vision, feeling tired and losing weight unintentionally. Types type 1, type 2 are the main types of the diabetes, wherein these were earlier called as insulin dependent or childhood onset for type 1 or NIDDM for type 2 adult onset. Other types which are considered mainly now are gestational and MODI, maturity onset diabetes of the young, neonatal. And one important section of diabetes is drug induced diabetes, wherein we normally see steroids, antipsychotics, antiretrovirals, CA chemotherapy, immune suppressants, thiazide diuretics, statins, beta blockers, all these contributing in their own mechanistic ways for the insulin resistance or insulin deficiency in the body or affecting the overall glucose metabolism. That too, specifically the antiretrovirals and CA chemotherapy drugs, they end up in causing irreversible damages. Other medicines, drug induced, though there will be impairment, glucose metabolic impairment, these are reversible once the drug are withdrawn. But retrovirals and CA chemotherapy drugs may cause, some of the chemotherapy drugs may cause irreversible damage to the pancreatic beta cells. One more important or interesting point to note in the type 2 diabetes is there are some categorizations in type 2 which are recently into considerations. And these are called clusters. There are 5 clusters noted in that: severe autoimmune diabetes, severe insulin deficient diabetes, severe insulin resistant diabetes, mild obesity related diabetes, and mild age related diabetes. These are the different clusters identified in type 2 diabetes. So here in autoimmune, usually it is low BMI persons and onset in the young persons. Similar for severe insulin deficient diabetes. For insulin resistant cluster, it is usually the patient is overweight and there is a risk of NAFLD, that is non-alcoholic fatty liver disease. And other 2 mild categories, the one obesity related, there it is not a typical metabolic syndrome kind, but the metabolic conditions, there is a less prevalence, hence it is a mild condition. And there is another cluster which accounts for around 40% of the cases seen is mild age related diabetes. There is mild increase in the blood sugar levels and no very specific systemic features. What are the risks associated with the diabetes condition? In Ayurveda also we call this as Prameha Anushangina. There is a risk of complications. So damage to the blood vessels, kidney, eyes, nerves, brain, gut. These are the very well-known risks associated with diabetes, which lead to or which may lead to heart attack, kidney failure, loss of vision, nerve damages, memory loss, and digestion problems. Recently, there is a T3DM, type 3 diabetes mellitus, which is in relation to Alzheimer's. That is the encephalopathy related to diabetes, which leads into memory loss. It is some call it as type 3 diabetes mellitus. And the problems related to gut due to diabetes are also very significant, which are not generally discussed more, but there is a significant impact on gut due to diabetes mellitus. Apart from the blood sugar levels, some of the key factors that are considered in diagnosis and management and monitoring of the prognosis are lipid profile, blood pressure, liver profile, and renal profile. Usually we find many comorbidities related to these organ functions in a diabetic person. The diagnosis is ideally based on both clinical parameters and laboratory parameters, and as per the ADA it is considered pre-diabetes, diabetes, and based on 3 marker tests: HbA1c, fasting blood glucose, and postprandial or OGTT blood glucose. Ideally fasting should be 126, less than or equal to 126, or in the range of 100 to 126, postprandial in the range of 140 to 200, and HbA1c in the range of 5.7 to 6.5. So with that overview of the understanding of diagnosis from the modern point of view, we will briefly note the understanding of Prameha from Ayurvedic point of view. So 2 things, one is Prameha, the other is Madhumeha, or also called as Ojomeha. Prameha is a big domain, like it is, there are 20 types of Prameha. It is described as Prabhuta Avila Mutrata or Prabhutam Varam Varam Va Mehati. So this is the characteristic feature of Prameha, that is excess and turbid urination or excess and frequent urination. These are the characteristic features of Prameha. In all the 20 types of Prameha, this is characteristic. In Madhumeha, typically it is called Madhumeha because the Madhuvat color, and there will be Ojakshaya Lakshanas because Ojomeha, Oja is being lost through Meha. And other features we should consider here is the Dosha Anubandha and Dosha Pradhanata. What I mean by that is, like Prameha, we have Kafaja, Pittaja and Vataja Mehas. In Kafaja Meha, there is a possibility that Pitta Anubandha may be there over a period of time. Similarly, Vata Anubandhata may also be there over a period of time. Whereas typical Vataja Meha, that is Vata Pradhana dosha, is present in Vataja Meha. So the prognosis differs depending on the Pradhana dosha and Anubandha dosha. And this Pradhana dosha and Anubandha dosha identification is important to note, and hence the history of clinical presentation over years is required. So some bringing some brief discussion about some of the cases. Case 1, a 63-year-old female, diabetes since 6 years, non-hypertensive, no cardiac illness, lipid profile normal, blood sugar levels normal, but there is consistently FPS was above 150 and ppbs was above 300 and no clinical symptoms of diabetes. So here for me there is a challenge in diagnosis because there are no clinical symptoms, there are no specific Purarupa Lakshanas of Prameha, and no comorbidity conditions. Lipid profile is normal. Patient is clinically normal, but laboratory values suggesting over a period of 6 years under treatment, but still it is above 150 for FBS and above 300 for ppbs. So should we consider it as Purarupa, or should we consider it as Kafaja Meha, or is it something mild age related diabetes mellitus? I will come back to these discussions because in coming slides I will be presenting few more points. Similarly, another case, a 60-year male, obese, known case of diabetes type 2 since 10 years, hypertensive since 12 years, mild elevated creatinine since 6 months, hypothyroidism mild since 1 year. So these are the presenting patients, symptomatology of the patient who wants to switch to the Ayurvedic medications, particularly for diabetes mellitus. So in this condition, patient has a lot of comorbidities. There is renal function is also affected. Patient has hypertension, and this is over 10 years. Patient still presenting the features, many features related to Kapha dosha. So should we consider this as Kafaja Meha, or is it Kafaja with Vata Anubandhata, or is it more of a Vataja condition? So these are some of the possible differentiation for diagnosis. In a case 3, like 48-year female, hypertension, diabetes since 7 years, hypertensive 5 years, and RA since 15 years. Renal profile is normal, fatty liver and hypothyroidism. So is it autoimmune diabetes, or is it steroid induced diabetes, or should we consider it as a Pittaja condition considering involvement of liver and thyroid condition and hypertension, and or is it more of Pitta with Vata Anubandhata? So what are the basic challenges that we face is, in clinical diagnosis of Ayurveda, we have the set mentioned, that is Purarupa, Rupa and Upadrava. In Prameha Purarupa itself, there are some symptoms like Galatalu Shosha, Asya Madhurya, Karapada Daha, Mutre Pipilika Abhisarana. These are mentioned in Prameha Purarupa condition. Generally we see, for example, Mutre Pipilika Abhisarana is a state wherein there is already loss of glucose through urine, which is after the state of raised blood sugar levels, and still we are considering this as Purarupa. And Karapada Daha, in most of the cases it is because of peripheral neuropathies, which is only a later stage, seen in later stages of Prameha or Madhumeha, but still we consider here it as Purarupa. And Asya Madhuryata may be considered as one of the main markers, like salivary examination with actually there are studies like salivary markers being taken as measuring for the prognosis of the condition. CRP levels in saliva, for the monitoring of the glucose control in diabetes. So whether we should consider this as Pura Rupa or these are Rupa or Upadrava, or is it because of the nature of the disease which is very chronic, so is it kind of overlapping of symptoms or extension of Purva Rupa into Rupa and then into Upadrava? So that is one of the challenges in the clinical setting, to consider this as Pura Rupa or Rupa or Upadrava. In that sense, making a treatment decision, planning treatment becomes difficult. Similarly, in Rupa, we have to consider dosha adhikyata, the status of dosha leenata or dosha kshayavastha or dosha kshinata. So based on the dosha status only, we will have to plan either it is shamana or shodhana. So in that sense, we have to have a clear understanding of dosha avastha in Rupa. In the previous cases, like here for in this case, the patient is typically kapha and medasvi and having kaphaja, but the condition is over 10 years and there is there are comorbidities associated with this. Considering kaphaja meha symptoms here, it will be difficult for a clinician to plan vamana karma or shodhana karma in this case because of the comorbidities. So diagnosis, not only diagnosis, treatment will also become challenging in such cases. But that is a clear case of kaphaja prameha, wherein because of other factors, shodhana treatment becomes very difficult. And also classics mention the involvement of meda, asrik, shukra, ambu, vasa, lasika, majja, rasa, voja, pishita. So many dhatus involved in the pathogenesis of prameha. These are different pramehas, will have different predominance of individual dhatu or upadhatu here, but still all are involved in the process of pathogenesis of prameha as mentioned by the classics. So then considering individual lakshana of this particular dosha dhatu dushti in a patient is also difficult, and in the absence of such dushti, planning or diagnosing is also difficult. So that is one of the challenges faced in the diagnosis. And also vojakshaya lakshana, considering madhumeha as ojomeha, there may not be typical vojakshaya lakshanas in a patient, but like murcha, pralapa, which are mentioned for vojakshaya. In that condition, planning a treatment or managing the crisis there is also difficult for Ayurvedic person. But vojakshaya is happening in madhumeha. So here there are no vojakshaya lakshanas specifically mentioned in the context of madhumeha, but considering it is oja is being decreased in that, have to consider vojakshaya lakshanas as part of disease lakshanas. And then there is upadrava dhatukshaya. So whether dhatukshaya is there initially or only has occurred later, that also becomes important in diagnosing. Another challenge we face, like in 20 types of prameha there are mentioned: kaphaja, udakameha, ikshurasameha, sandrameha and all. Pittaja we have 6 types of prameha, and vataja we have 4 types of meha. So here some consider, like drawing from my discussions with some of the stalwarts in Ayurveda, when I went to them with my own doubts, so some were mentioning like kaphaja meha is more like pre-diabetic state, whereas pittaja is proper diabetic condition state, and vataja is a complication stage. So for me it was, and it made me even the concept more complicated. I'm not very sure whether it works like that. And then the duration it takes for the samprapti to set up itself poses different challenges for the diagnosis of prameha. So, and to distinguish whether it is kaphaja or pittaja, some of the authors consider it to be pittaja to be more of infections in the pittaja is some comorbid infectious condition in prameha, and vataja is where the organ damage has occurred. So more like these 20 types representing the different states of prameha. So that is also to some extent it is logical, but still it makes difficult to understand different types of prameha. The reason being, in classics they have mentioned like if it is kaphaja is not treated properly, it ends up in pittaja, and then if it might end up further, it ends up in vataja. So we have 10 kaphaja prameha, and then 6 pittaja, and then we have 4 vataja. So theoretically speaking, there are different possibilities of the clinical progression of the disease. 20 types of Prameha which can be considered, or there are possible 240 clinical presentations considering the progression of the disease, which means there are possible when it comes to the Vataja Meha, the chance of a person ending up into Vataja Meha from Kafaja Meha, there are possible 240 clinical process or clinical progressions possible in that, so which is very difficult to clinically understand that. If we consider whatever the status of meha in its kafaja state, it will surely end up in the pittaja presentation will be the same for all the 10 kafaja mehas. Then we can consider like the only end result possible in that progression will be only 4 possibilities. But when we consider the clinical taking history of the patient over the years, not all patients will have the similar progression, and not all patients will have similar comorbidities, so which makes a whole set of clinical possibilities in the by the time the person ends up in Vataja Meha. So this is one theoretical possibility, and a clinically it is seen also, like different patients have different types of clinical progressions. So what are the management goals that the guidelines tell us? Relief from symptoms of diabetes and improvement in quality of life, glycemic control and prevention of acute complications, identification and management of comorbid conditions like obesity, hypertension and dyslipidemia, prevention of microvascular complications like retinopathy, neuropathy and nephropathy, prevention of macrovascular complications like cardiovascular, cerebrovascular and peripheral vascular disease, prevention of infections. Looking at this at the outset, it is quite possible for an Ayurvedic physician to achieve these goals by making use of only Ayurvedic treatment protocols, using Shodhana therapy, Shamana therapy and Rasayana therapies. It is all these are clinically this is all quite possible. Relief from the symptoms of diabetes and improvement in quality of life, which is very much achievable, and in fact Ayurveda and yoga give best results in improvement of quality of life and relief from symptoms. Next is glycemic control and prevention of acute complications, which is a bit difficult, or which is not easily achieved through Ayurvedic medicines in my clinical practice. And also when I discussed with my seniors and other practitioners, they also had similar opinions that the patient gets better, patient is clinically doing very well, but somehow the glycemic control is not happening as desired. So this is one of the challenges, because unless there is a proper glycemic control, the patient is not happy, and it is not very clear to the physician whether he has actually achieved the treatment goal, because there is a chance, as per the modern textbooks, that even in a very much controlled glycemic environment also, the risk of end organ damage is still there, but it might be prolonged, but it is still there. But with uncontrolled blood glucose levels which are not in the desired range, there is a definite chance of end organ damages, which is quite much earlier compared to the person with good glycemic control. So in that sense, it is not wise to neglect this glycemic control aspect, stating that the patient is doing quite well. So which is sometimes very difficult. So here I feel the concept of dosha leenata comes in picture, because unless the more treatment that is generally given is more of shaman aushadhis, because at times shodhana is not feasible because of some comorbidities, and as long as there is shamana in place, there is a chance of recurrences, or there is a chance of dosha uttishtata, and hence though the samprapti is being addressed, the dosha status, typical dosha vruddhi status is not being properly addressed. I feel that is one of the challenges. Coming to the Ayurvedic management, what are the options we have? Acharya Charaka states Kafaja is very much curable. Samakriyatvat, Vishamakriyatvat, Mahatrayatvat cha tatha kramena. He gives the reason also. So for Kafaja, it is the plan is Samshodhana, Ullekhana. That is Ullekhana is again Vamana type of Samshodhana, and Langana part of Shamana. For Pittaja, Virechana and Santarpana and Samshamana. And for Yapya conditions, it use of Siddha Tailas, Vritas and Kashayas. This is in brief the protocol of management, and also the consideration of Sthula Pramehi Balavani Heka. Sthula and Krushata are the main consideration factors to choose for whether to go for Shodhana or Shamana. Acharya Sushruta gives similar suggestion or similar guideline, but he says Vamana, Virechana, Basti followed by Kashaya Yogas, and same Kashaya Yogas for Apya also you can use, and clear Patya Apatya Kalpanas he has given. So here the flow of treatment guideline given by Acharya Sushruta suggests Vamana and Virechana can be given for all the sadhya conditions, whereas the commentators there mention it has to be only based on the dosha vikalpa and the bala of the person. It is not necessary that one has to go for Vamana, Virechana, Basti in all the cases. So this is the prognosis we see or we expect in Prameha conditions. Samakriyatva, usually for Kafaja conditions it is possible because of the Samakriyatva, it is still in the range of, like we can say, the green area of the spectrum. In Anubandha Yukta conditions also there is a possibility of proper reversal of the condition. And in drug induced there is a once the drug is withdrawn there is a fair chance of reversal, and accordingly the later it can be managed. Vishamakriyatva is for Pittaja Pramehas and conditions where comorbidities are involved, so then it will be difficult to plan, or the physician has very less space for Shodhana and Shamana planning. Mahatrayatva conditions is more of Apya condition because Vata is involved, organ damage is happening, complications are setting up, so it will be a more prognosis wise it is difficult. Some of the things that we can discuss as challenges is meeting management goals that are set by the guidelines. That is one of the challenges, because the patient who is already on a allopathic medication regime comes to Ayurvedic physician many a times to move from the allopathic medication to the Ayurvedic medication completely. So now it is on the onus on the Ayurvedic physician, like how smooth this transition can be without causing any complication or any unwanted effects on the patient, which is quite possible. Like the patient can move into the whole Ayurvedic regimen, but how it has to be managed, that is one of the major challenges. Whether we have to have our medications as concomitant medications like add-on therapies, or it has to be a total replacement, because diet and exercises are common in both. We also suggest diet and exercises. Maybe yoga is also common nowadays in both the streams. The only thing that differs is the Ayurveda medications, whether we want to plan for Shodhana and then Shamana, or we want to go for directly Shamana, and how to move about this transition, that is the main challenge. And from the physician point of view, lack of more data on the adverse effects or whatever reported adverse effects on different herbs or combination of herbs, that is also one of the key things that we have to consider from the practice point of view. So there is a requirement of pharmacovigilance and some other parameters for follow-up and data collection, which we'll discuss. Briefly we will go through the modern medications that are given, so that where as Ayurvedic physicians we can pitch in, so that becomes more clear for us. So what is the modern medications do? Either they are secretagogues, help in pancreatic insulin secretion, or they are sensitizers to sensitize peripheral tissues for insulin absorption, and impair gastrointestinal absorption of glucose or increase glycosuria. And then there is insulin therapies. We have sulfonylureas that act as insulin secretagogues, and there are different Gen 1, Gen 3. Third generation is considered to be more safe and better acting than the first generation. What they also do is they also promote hyperinsulinemia. The adverse effects, they cause weight gain of 2 to 5 kgs. They can potentiate insulin resistance and thus lead to hypoglycemia and renal insufficiency also. And in the long run, they can just exhaust the beta cells, making it need to add more drugs. This is in case of sulfonylureas, one of the main group of drugs required for diabetes management. So considering these areas of adverse events, so we can avoid these by the use of Ayurvedic medicines, which is one of the scope for Ayurvedic medicines. Short-acting insulin secretagogues like repaglinide and all, they have low risk of hypoglycemia. They also can cause weight gain, and they not work in patients resistant to the other drugs. So these are the limitations of these secretagogues. Biguanides, metformin is one of the most commonly prescribed medicine, considered one of the safest drug for diabetes. It increases peripheral insulin sensitizer. It can lower lipid levels. So these are the additional advantages of metformin. Decreases GI absorption, but it can also cause dyspepsia, diarrhea, because it lowers the GI absorption of glucose. Hence, it can cause vitamin B12 deficiency also and weight loss also. Thiazolidine diones like pioglitazone, rosiglitazone, very commonly prescribed drugs. These improve lipid profile, may be helpful in NAFLD, but they can cause peripheral edema, weight gain, CVD, and even fractures. So there has to be a continuous monitoring. And when Ayurvedic physicians want the patient to discontinue these medicines, they have to take care of these, like medicines which can definitely replace this action, but also educate the patient like these were the possible adverse events that would have happened. And some more drugs will not go in detail. So what is the scope? Basically, the diagnosis, we need to consider a Shatkriya Kala based diagnosis. What we mean in that is the initial dosha avasthas of Sanchaya, Prakopa, Prasara, it is more related to the initial impairment in the glucose metabolism. Whereas later, from the Thana Samshraya Vyakta avasthas, it is the beta cell functions are hampered and the hyperglycemia is set in. So that is the state of Vyakta avastha, wherein and the later complications we can consider as Bheda avastha. So this is in considering this Shatkriya Kala approach, the diagnosis has to be made. Apart from the dosha specific diagnosis, the staging of the disease has to be made on the Shatkriya Kala. That is the only way possible for us to pitch in whether to go for Shamana or Shodhana, or to go for a combined approach or comprehensive approaches. And Ayurveda has some unique role to play, considering the preventive Shodhana it can offer. So in the early stages or pre-diabetes stages, if the person undergoes Shodhana, then the course can be prevented. Then the primary Shodhana Chikitsa in the early stages of diabetes, and secondary Shodhana Chikitsa. Shodhana in Shodhana Yogya conditions, even in later conditions, like in Stula persons, in a Dosha Pravruddha Avastha. Considering secondary Shodhana is very important to prevent the organ damages. So that we can consider as tertiary preventive cares, which includes Rasayana Chikitsa and some of the external therapies like Lepas and Parisheka kind of things, which are also very unique offerings of the Ayurvedic medicine for the management of diabetes. There is another scope that we have to consider from the practice point of view, like harmonization of these therapies. First, the intervention points, considering the different clusters and different stages of diabetes as per the standardized diagnostic criterions. We have to, or there is a scope that we can consider intervention points in the Prasaravastha or Sthana Samshraya Avastha. What are the interventions that are possible in different clusters of diabetes? Or we can have our own defined clusters from the Ayurvedic diagnosis point of view, like it is very much accepted by the classics. They say Bheta hi Bhedyam Anyatha Bhinati. It is not only that we can consider these 20 types, we can have our own for the management point of view, diagnosis point of view. Some clusters of diabetes we can consider, so that the care can be defined, whether it has to be a general care in a OPD setting, or it has to be a specialty care, or it has to be even the crisis management. The later some complications also can be managed by Ayurveda once we define the intervention points. So these are some of the scopes that I feel which are possible. And pharmacovigilance is very important from a practitioner point of view. Large scale data collection, event reporting, and making that information available to all the practitioners, which will help in decision making for the treatment planning. We agree that there are a lot of treatment protocols very specifically mentioned in the books, and we have more than thousands of medicines at our disposal for giving to the patient, but still there is some need felt for the proper guidelines to what type of rasayana should be given in what intervention point, whether it has to be bhallataka or it has to be shilajitu, when we have to go for ghrutapana, when it has to be taila administration, and what is the how the basti can be helpful in complications management, vata management. So these are to make some decisions, we need some more data from the clinicians from pharmacovigilance point of view, and parameters for follow from Ayurvedic point of view, and the data collection which will help in understanding the practice better. So with this, I conclude my session. This has been, the subject itself is so huge that it is not quite possible to touch all the corners of the subject. I just tried to bring in few points from practice point of view for the discussion in front of this august audience. Thanks a lot.
Is Karapada Daha equal to peripheral neuropathy? So that is Vasanta Reddy madam's question, sir. Padmanabh sir.
There may be some different causes like vitamin B12 deficiency and all. In this particular the case of Prameha, I think we can consider peripheral neuropathy as one of the differential diagnosis points, because there is in the same line they are also considering Mutre Pipilika Abhisarana, which is also a symptom seen in later stages when there is glycosuria. So Karapada Daha is also in many patients it is one of the presenting symptoms. Like Karapada Daha, patient approach with that, and when tested we find them to be hyperglycemic. So it is quite a candidate for consideration, the peripheral neuropathy as Karapada Daha, sir. This is my opinion.
Okay, sir. Anybody presenting with Karapada Daha, any case presenting with Karapada Daha should be pushed on for further investigation of Prameha or diabetes, whatever it may be, sir?
Sir, especially so if the person is an elderly person and any signs of metabolic syndrome or metabolic derangement, yes, definitely we need to consider this as one of the diagnosis.
Simple tips how we would manage that.
Manage Karapada Daha. Yes. Teka is one of the treatments, and Abhyanga is one treatment like Prasarini Taila or even Kshirabala Dhanvantaram also help in reducing Karapada, sir. Regular Abhyanga with this Vatashamaka Tailas.
The question I have is, how do we, a lot of us would want to take Ayurvedic medications alongside allopathic medications. What can we do a lot of times the allopathic doctors say, no, you can't because they can be drug interactions. Will they be drug interactions, number one? And if not, how do we convince them that, there will really be no drug interaction, and what can Ayurvedic doctors do to help us do that?
Sure. In my opinion, I consider when we say our drugs are really acting, they help in reducing the overall pathophysiology of the disease. They must be acting on glucose metabolism. So there is a possibility of drug interaction, and one way to rule out is to carry out drug interaction studies for that particular medicine and be available. Make that data available to the practitioners. That is one best way of doing it, and surely we can show that to the whoever expert, like this is the data we have, so there is no drug interaction, or if it is drug interaction is there, then we have the data. So there can be a dosage alterations, and like I mentioned, once we know what is best for the patient, if allopathic medicine is the best for the patient, then fair enough. Like we suggest our patient to go ahead with that. But if the patient is under the risk of experiencing adverse effects, and there is an Ayurvedic better alternative, then patient has to be even the allopathic physician has to accept that going with the Ayurvedic medicine is required for that particular patient. So we have medicine, like there are normally we prescribe Nishakatakadi and Nisha Amalaki and all, which actually lower the blood glucose, which help in lowering the lipid profile, making the lipid profile normal. So there is an definite evidence and action of Ayurvedic drugs. So with that evidence, I mean, we can show it to any physician.
So,
So
in other words,
in
it
other
means
words, it
that
means
there
that
can be
there
drug
can be drug
interactions,
interactions,
and it's
and
best to
it's
use
best to
either
use
one
either one
at a time,
at a
right?
time, right? Not necessarily, madam. Like both are possible because I prescribe in my practice along with allopathic. I prescribe some of the Ayurvedic medicines and ask the patient to lower the dosage of allopathic medications so that gradually I can keep monitoring the blood glucose levels and other hematological parameters, and then once the patient is stabilized, I can go for the next step of taking out other allopathic medications. So that's how I try to make the patient also comfortable, and there are no sudden rise in the blood glucose or some sudden adverse events, because I think when we take out the other medicines and there is no proper control of blood sugar levels, I think this is one way of making the dosha utklesha. And when we, because all these are shamana aushadhis, and once the shamana effect comes down, there is a chance of dosha utklesha again happening. And this dosha utklesha, if it is over a period of time, the patient is still having hyperglycemia over a period of time, there is a chance in a prone patient, like we may find some alterations in the liver profile or renal profile. And if we are planning for some shodhana chikitsa for a patient, then we can consider straight away, like even in dosha utklesha condition, we can plan appropriate shodhana and go for it, so that there is we are not affected by the dosha leena avastha as such. So dosha utklishtata may be there. So this is one possible way of approach.
Is Vata Meha manageable? First one. So when we manage properly the Kafaja Meha, what are the chances of it turning this as Vataja Meha? So two questions there, sir. So combined, is Vataja Meha manageable? First question. When we manage the Kafaja Meha in a proper way, what are the chances of it turning this as Vataja Meha?
Sir, once, I mean, when we say we are properly managing the Kafaja Meha, then there is almost nil chances of turning it, into Vataja Meha, because we have managed it properly. Only when it is not managed properly, it may become Pittaja Meha or Vataja Meha. And Vataja Meha is quite manageable. I mean, it is manageable only, like apnea condition. There are yogas, Rasayana yogas mentioned in the classics, and also Sneha yogas, which are specifically mentioned for Vataja Meha. Those can be given in the patient. The main challenge again comes here is the comorbidities. Like if we are planning to give some Sneha Prayoga, Shamana Yoga, first is we have to make the person Deepana Pachana properly happening, which is again one of the gut is affected because of oral hypoglycemic agents, and giving proper Deepana Pachana, then go for Snehapana, and we have to be monitoring the liver profile and renal profile properly throughout our Snehapana procedures, and then go for Kashaya yogas and Rasayana yogas.
Thank you there, sir.
Thank you there, sir.
So generally, when we consider Vataja Meha or when Vata is involved, the term Asadhya is usually correlated there. So you said it is Yapya and it is manageable. That's why the question.
Yes, yes, sir. Yeah, Yapya is a type of Asadhya only, sir. Pratyakaya, it is not Pratyakaya, but it is Yapya only as per the book, sir.
Okay, I think the question was in that direction. One more question from Dr. Padmathi is many dietitians advise methi seeds for diabetics and people with obesity and hypertension as well. How methi seeds help to reduce the blood sugar, obesity and hypertension? Or at least from a dietetic perspective, can methi seeds be used by those having diabetes and also obesity and hypertension? Your thoughts?
Yes, sir, definitely. Like Methi is one of well-known and most widely used in diabetes management. Some use it in fry it and powder it. Some use it soaked in the water and all. But like again in this, there is a chance of sometimes excess karshana happening if the person is taking lot of kashayas and all, ending up into vatajameha from kafajameha. There is such chances happening. We have to guide the patient properly, like what should be the dosage and the number of medications, because homemade medications people they take on their own, which are also having effect on the blood sugar levels. People take, like it becomes like multi pharmacy kind of thing, so we have to properly guide them to limit the medications for the proper glucose monitoring, sir.
One more question from Dr. Saujanya Kashyap here. Please share your clinical experience and Shamana Aushadha you will usually prefer in Kafaja, Pittaja and Vataja Prameha respectively. So in these conditions, your clinical experience in brief, sir.
Normally, Nisha Katakadi, Chandraprabhavati, Shilajitu Yogas and Nishamalaki, these are the commonly used medications. Sushruta's version of Kashayas, one Kashaya for each type of Prameha is ideal, I believe. Again, the main challenge in practice is to identify that particular Meha with 100% accuracy. That becomes the challenge. Once it is diagnosed, we have many treatment options.
In Pittaja and Vataja and Kafaja, any specific choice of medicines you have, sir? Like your secret formulations, like which you practice and which has yielded good results very constantly?
No any secret formulation, sir. I use regular classical medicines. Classical medicines only I am using, sir.
From Pallavi Bidarji, so like if Karshya patient, diabetes patient is also a Karshya, have more levels of blood sugar, then whether we should opt out for Shodhana or Shamana treatment?
No, Kasha by default it is unsuitable for Shodhana. We have to go for Shamana only, and like Santarpana has to be done because the person is Kasha, he is unfit for Shodhana, sir.
Going back again to Padmavati Raiji's question, so doctor should be mutually intimated. What do you think, sir? Like even an allopathy doctor should know that a particular patient is taking Ayurvedic medicines also parallel to the modern medications, so that there is no overload of medications.
Exactly, sir. I agree with that point 100%.
Dr. Saujanya Kashyap's question again, what is your opinion regarding flush out period from allopathic to Ayurvedic treatment protocols?
I have not planned any specific flush out period, but yes, I always prefer to make it step by step, like around 15 days or 1 month period to withdraw one medication likewise, and just try to understand the pathology more, so that we will understand why that particular medicine was given, whether it was sulfonylurea or biguanide, because the person may be taking beta blockers, ACE inhibitors, and there may be other comorbidities, and what is the role this is helping in those pathology, in reducing those pathologies. So we have to do some planning work for using Ayurveda.
Okay, thank you there, sir. And a couple of compliments also coming your way, like Kalpana ji writes, wonderful presentation. I love to hear all these experts on Wednesday. Is it possible to include or share some of the success cases along with treatment plan that was used? Surely Kalpana ji, as and when possible, we'll keep sharing. And I think Sandy ji also has something to share here. Sir, in Prameha, Sadhya Vamana or Vamana followed by Snehapana for 3 to 7 days should be done. That is a question. Should like Sadhya Vamana or Vamana followed by Snehapana for 3 to 7 days. What is ideal?
I think it has to be proper Vamana karma, sir, because we are not doing any avastika chikitsa to carry out Sadhya Vamana like in Tamaka Shwasa. It has to be a classical Vamana karma for Kapha Shodhana, I believe.
Similarly, even Virechana, like Nitya Virechana or Virechana, I think the answer will be the same. Like we should go in a Krama.
Yes, sir. Yes.
Okay. Abdul Karim sir has a question here, like question or a thought. Dose and time of administration is maintained, means I think there is no interaction between any system of medicine, as my opinion. Oh, thank you, sir. There. Yeah, Vasant Reddy madam's question was there to Dr. Karim. Would drug interaction not depend on half-life of the drug in the system? Your thoughts, sir?
Yes, sir. That is true. But if you have data, like experimental data on the drug, whether it works on these CYP enzyme pathways and all, then it will be more clear like, is there any chance of drug interaction possible from Ayurvedic medicines? That is true. Half-life point is well taken, sir.
Thank you, sir. Why it is called as Madhumeha? Probably that is the question, sir. Why that condition is called as Madhumeha?
Sir, mostly because the urine color is little towards the honey color, and also the taste is very sugary. So that's the reason it is called Madhumeha. By the time urine becomes such nature, probably there is already renal damage is happening.
One wonderful question by Pallavi Bidarji once again. So let's consider a patient is having a family history of diabetes. Can we prevent it? Number one, if yes, what type of rasayana should we start?
Yes, at least it can be delayed, and it is by the help of Shodhana, and like Rasayana again depends on the dosha avasthas. Ideally, we can go for Shilajitu Rasayana. That, in my opinion, we can go for Shilajitu Rasayana.
Pallavi Bidarji, once again, if we give Santarpana to Karshya patient with more level of sugar, whether it will again increase Meda and Kapha. Santarpana Chikitsa would increase Meda and Kapha when it is given to a Karshya patient. That is the question, sir.
Sir, Santarpana is not necessarily given by sugary recipes. Santarpana is to say that the Vata Shamana and to improve the quality of Rasadhatu. The goal of the Santarpana treatment would be likewise, and the recipes or the medicines has to be planned accordingly. But Shodhana is not possible, and it has to be Guru Apatarpana kind of thing, but it could be Guru, like Laja Tarpanas and other things we can consider. But essentially, the treatment falls under the category of Santarpana. So it is not having any sugary recipes.
Thank you there, sir. I think is diabetic peripheral neuropathy curable or only manageable? What do you think, sir?
Sir, it is manageable.
Thank you there, sir. I think we have come to the end of the session, and also we've taken almost all the questions, and a special thanks to Padmanabha sir, Dr. Padmanabha Rugvedi sir. Thank you, sir.